So hello to everyone who's joining us. I'm just going to wait a minute or so more and then we'll get started. Okay, so let's make a start. Hello, everyone, and welcome to this webinar, which is the HCRI end of term lecture, but it's also an important event, I guess, towards the end of a funded project from the ESRC into LGBTQIA plus experiences of COVID, conducted here at Manchester, led by myself. So a couple of housekeeping things first, and then I'll give an introduction to the webinar, and then we'll move on to our speakers from there. So the first thing is just to let you know, if you don't know already, that the session is being recorded, so it'll be available after. And if you want to ask questions, in either during the talks, and we can answer them in the discussion at the end, or during the discussion, yeah, you can use the Q&A function, and we'll have a combined discussion at the end of each of the 4 presentations. And also at the end of the webinar, there'll be a short survey that will pop up on the screen for you, which is just a few questions about how useful you found today's session, or whether you found the research interesting, and things like that, which help us kind of in our reporting to funders, but also gauge yeah, how meaningful the research is and what we can do in the future with it. So if you don't mind filling that in, that would be much appreciated. Okay, so a couple of acknowledgements. The first one is that I am currently in Sydney, Australia, so I acknowledge and pay respect to the Gadigal people of the Eora Nation, the traditional custodians on the land on which I am currently working and attending this webinar from, and I pay my respect to their elders past, present and emerging. I also want to quickly acknowledge the UCU strike action that is occurring. This webinar is occurring whilst our colleagues are at UK universities are protesting against pay and work conditions, and I'm aware that we're holding a webinar during that, so I wish to express some solidarity with those who are striking, and really just encourage anyone participating who isn't aware of those to, particularly if you're from the UK, to just engage with those issues and kind of see what they're all about. So you have a bit more awareness for yourself if you don't already. I also want to acknowledge that today is World AIDS Day, with various themes from the US. The theme is ending the HIV epidemic, equitable access, everyone's voices. The World Health Organization has a theme of end inequalities, end AIDS, with a special focus on researching people left behind. So I want to acknowledge those impacted by HIV AIDS throughout past decades and into the future. But also, I guess, in thinking about today's topics and LGBT plus people during crises in general, a group that is traditionally left behind, without equitable access and whose voices need to be more centered in crisis responses and disaster risk reduction, as evidenced by many of the findings from our various COVID-19 research projects, which our speakers will be discussing today. So on that note, I want to thank all of our fabulous speakers for their time and energy in presenting their research today and telling their stories. We'll hear from me first, who, if you don't know, I'm a lecturer in disaster management at HCRI and lead researcher on the project at Manchester that's hosting this event. We'll then hear from Jack Lopez, who is Associate Dean of Equality, Diversity and Inclusion at the University of Bradford, and a researcher examining many community and social health topics in various parts of the world. But I guess of most relevance today is his work on the impacts of COVID on adult trans healthcare access in the UK. And we'll then hear from Luan Casal, who is a researcher on the project at Manchester, but also a PhD candidate in the Manchester Institute of Education, analysing requirements of time and age in the British Gender Recognition Act and its reform proposals. Followed by Mariah Rafaela Silva, who's Black trans human rights activist and project coordinator of Grupo Conexão G in Rio de Janeiro from the Fluminense Federal University in Brazil. And then, as I said, we'll have a discussion afterwards. So before we get to my presentation, you might be wondering why we're exploring these topics in the UK and Brazil. Well, the UK and Brazil are instructive case studies as they represent very different social, cultural, economic, and political contexts in which the same crisis of COVID-19 is impacting, which provides us an opportunity to uncover perhaps common learnings and important differences in LGBTQIA+ responses to and experiences of humanitarian crises. And in our case, professional research and personal connections to both contexts facilitated work in those regions as opposed to others. So a bit of background to both cases then. For the UK, in early 2020, the first cases of coronavirus arrived with restrictions placed on businesses implemented in late March, and in April with pressure building on the National Health Service, and then leading to what was the first of several national lockdowns. And the UK then had alternating periods of lockdown and relaxation throughout, and other COVID-19 restrictions as well, including a system of tiers at one point throughout the rest of 2020. And various aspects of that received numerous criticisms along the way. And the extended periods of lockdown were said to increase social and economic damage, while periods of relaxation would trigger more deaths, with the most disadvantaged groups in society suffering the most in both scenarios. For instance, mental health across the UK had deteriorated during 2020, with uneven impacts across population segments, indicating persistence of socioeconomic and health inequalities. And we saw disproportionate impacts on people of colour, for example, people in aged care facilities and others. And then national lockdowns persisted into the winter with more transmissible variants of the virus before a gradual opening up of the national vaccine rollout in 2021. But of course, we know the crisis is still ongoing. And now in the UK, gender identity and sexuality are protected characteristics under the Equality Act of 2010, and therefore require special consideration. However, legal protections don't always guarantee equality and inclusion in life. And the National LGBT Survey from 2018 indicates inequalities among LGBT+ populations compared to the general population in a number of key areas. For example, people still avoiding being open about their sexuality at work, or transgender people reportedly having lower life satisfaction than cisgender people. In Brazil, similarly, the first cases of COVID were recorded in early 2020, with the initial response involving patient or home isolation and contact tracing. And then Brazil went on and continues to experience some of the highest COVID-19 infection rates and numbers of cases and deaths in the world, even with comparatively low testing rates. Despite past experiences of public health emergencies, Brazil appeared ill-prepared with early concerns about testing capabilities, the robustness of public health systems, and many other concerns. In particular around Brazilians living in favelas, indigenous populations, and potential health system collapse in inland municipalities. Brazil's response to the crisis was or is led by ultra-conservative President Jair Bolsonaro, who's received national and international criticism, including concerns over Brazil's response in general, but very much so direct criticism of Bolsonaro, who opposed World Health Organization recommendations, minimized the illness and its impacts, publicly dismissing it as a little cold, rejected scientific evidence, suppressed data, and politicized the health sector, with numerous public officials, including government health ministers resigning or departing their roles. And in particular in Brazil, federalism and the differences in territorial power dynamics resulted in sort of lack of coordination and asymmetrical approaches to the pandemic across states, regions, and governments. Despite recent changes for LGBTQIA+ rights, for example, legal self-determination for trans people in 2018, growing anti-gender and anti-gay rhetoric culminating in the election of Bolsonaro in 2018 has perpetuated a hostile environment for LGBT+ people in Brazil. For example, Brazil has some of the highest rates globally of transphobia-related deaths. President Bolsonaro himself is well known for being homophobic publicly, and a survey of LGBT+ Brazilians revealed almost 99% of respondents were dissatisfied with his pandemic performance. So the first thing I want to do for my part, if we call that part the introduction, and now this is my part, is play your video. So part of our project was to develop an animation video to explain the research, hopefully to a wider audience, covering aspects of both the UK and Brazil. So this is the first time I've played it anywhere, so lucky you. But please share it to many more people so that they can have the same joyous experience that we're all going to have. And then I'll move on to talk, of course, in a bit more depth about some of the themes in this video.
People in LGBT+ communities are often isolated from their families, and they may have lost friends in coming out. Many move to an area because they think it's going to be a happier place to live. So when you say to them, stay home, don't go to LGBT+ spaces, to your community groups, they're finding themselves very isolated and very lonely and depressed. Lloyd moved here seeking to be part of a community. And then all of a sudden he was shut off completely, which has taken a big toll on his mental health. In Brazil, the financial crisis is making many people like Laura feel unstable mentally, as she's worried about getting fired, and maybe not even having enough to eat at some point. She says being a black woman, she faces race and gender issues when seeking work, while being lesbian doesn't affect her as much because she keeps her personal and professional relationships separate. A lot of Prince's health procedures are on hold. If COVID hadn't happened, they would have had top surgery this summer. It's obviously been pushed back, but they haven't been told anything and they're heartbroken. After coming out at the age of 22, Prince had a personal goal that a lot of their medical transition would have been done by the time they were 30. but that's now become a very difficult hurdle. Mauro has always limited his circle of friends due to being LGBT+, as he came out when he was nearly 30. He says that in Brazil there are things happening that he's terrified of, discourses of hatred and violence, and that everyone is feeling particularly fragile during the pandemic. Mauro has been especially impacted by the reduced social network due to the stigma of being LGBT+. For many LGBT+ Muslims, life can be isolating because being gay often isn't accepted in their families and communities. Omar works for an organisation that supports them, and with COVID, they're now creating community online, such as through a Pride event with countries like Saudi Arabia and Egypt. Omar says there were people saying, "Wait a minute, I'm in Saudi Arabia, it's 3 AM, and I'm actually at a Pride." And those involved in running the events and being able to help others say that it has kept them going during COVID. The University of Manchester Studies' key recommendations are to involve LGBT+ people in response and policy making, prioritise access to disrupted LGBT+ services, allocate resources to support work already being done, develop international standards to improve responses, provide education and training on LGBT+ issues, and focus on risk reduction.
Okay, so the video highlights a few stories from our research interviews in both the UK and Brazil. And in my presentation now, I'm going to talk a bit more about the UK experiences that we documented, and later on, Luan will talk more about some of those Brazil experiences. And when I'm finished talking, I will put the link in the chat for you to the video. So I'm going to talk about, as I said, LGBTQIA+ experiences of COVID in the UK a bit more, but in particular, some of the challenges faced kind of from those collective analysis of experiences, and importantly also coping strategies and mechanisms that were adopted, and then give some attention to some ideas about ways forward for more inclusive disaster risk reduction. So the coronavirus pandemic and response measures have had disproportionate impacts on different segments of society, as already mentioned, and this includes LGBTQIA+ people. The groups most marginalised in disasters often have the least input in development of disaster risk reduction policy and practice from local to international levels, including LGBT+ people. And response strategies can heighten and reproduce vulnerabilities beyond just not including LGBT+ people in needs. And a UN report described exactly that for COVID-19, how responses around the world reproduced and intensified pre-existing exclusion and discrimination patterns for LGBT+ people. And various reports quite quickly in 2020 and throughout the rest of the pandemic so far emerged, documenting either predicted or actual risks and experiences of LGBT+ people in the pandemic around the world, with challenges like isolation, substance misuse, loss of livelihoods, housing, and many more reported. So our study in the UK was based on interviews via Zoom. I won't go into all of this detail, but just to say that we a bit different to sort of those broad scale surveys or international reports kind of predicting experiences. Interviews allowed us to get, I guess, valuable contextualized insights into individual lives from a diverse range of gender and sexual minorities. In particular, and we interviewed 17 people from the UK during what would be called the first wave, I guess, of the pandemic in 2020. So the first thing then is some of those key challenges faced, and many of the ones that we found align with other reports, but there are some more nuanced to be discussed as well. So the first and the most prominent issue raised was mental health and isolation. So this included anxieties about the virus and related to gender and sexual identity specifically. Isolation from supportive people and spaces caused heightened stress, with some having limited or unsupportive family, as Lloyd describes here and as we saw in the video. And related but further to that is loss of LGBT plus spaces. So disruptions to LGBT plus spaces were acutely felt during the pandemic, including nightlife, but also beyond this, and other spaces too. So community spaces, support groups, activities like pride events, for example. And these spaces usually provide many people with essential opportunities to freely and safely express themselves. As Lindsay describes here, on top of losing work, they also lost a place to truly express themselves, to release the tension of existing in a very cisgendered heterosexual society. Work and economic impacts were important. In particular, some industries like the hospitality and entertainment sectors have experienced greater impacts of social and economic restrictions. Concerns were expressed over income in the short term, but also anxieties around longer term employment, particularly in some sectors. And working at home, some transgender people described anxiety around using video conference platforms, for example, being read as their correct gender, adding to mental health distress in a way that would unlikely be experienced for cisgendered people. Discrimination and stigma, including from unsupportive family and people that were sharing lockdown with, but also in public spaces, and in particular in the media and online and social media were reported. Now, discrimination may not have been related to COVID-19 itself, but the fact that it was occurring during COVID-19 exacerbated mental health issues and isolation. Healthcare disruptions, especially transgender healthcare, relating to gender affirmation and gender identities, were largely delayed or cancelled, often without communication. And this caused confusion, anxiety, exacerbated mental health concerns, and added to the already very long waiting periods for gender identity clinics and the NHS. And as we saw in the video, something that Prince articulates very well, how heartbreaking it was to have their progress disrupted. But I don't want to talk just about kind of vulnerabilities or challenges, because kind of stories of people's experiences of COVID-19 are certainly much more than that. And in particular, coping capacities and kind of community support were really important findings from our research. So, and I guess what we might call stories of resilience, with people drawing on pre-existing coping capacities through their experiences of past marginalisation to develop collective resources to help themselves and others. So some things that the general population probably experienced as well. So things like adopting regular routines. Participants drew on coping strategies that they developed in past experiences. So things like, the timing of activities in the day, diet, monitoring alcohol consumption, sleep patterns, and so on. Many people spoke about talking to friends or therapists, in particular, friends who were going through similar experiences was helpful. And socializing online, including activities like video calls, games, and so on with friends and family. And also increased use of dating apps, not necessarily to meet up with people, but for community and for social support. But we should consider inequalities here, and that some people may not have had access to such technologies and therefore coping mechanisms in the same way that others did. But really importantly, as I've already touched on, was the role of LGBT plus organizations, community groups, and peer support. So existing and new community groups filled gaps in providing mental health support and reducing isolation through mutual aid and the creation of safe and identity affirming online spaces. And moving activities online actually presented opportunities to connect with new and diverse audiences, in some ways improving accessibility. And again, as we saw in the video, Omar here talking about going virtual with their support activities for LGBT Muslims, and then the kind of extra benefit of being able to reach further afield to other countries around the world where it's against the law to be homosexual, and where people can't express themselves freely. And then from Ken here, talking about a community group that actually existed before COVID, now largely led by trans and queer women. And in this case, they held many online events, weekly social support, but also online cabaret events. And the key point here is that they talk about running those events was what was keeping them going during the pandemic. So being able to express themselves and run something, gain new skills, but also that feeling of helping others and being able to pass that on. So this online community support, in particular from community groups and peer support groups, has multiple benefits that are of significance for LGBT people during the pandemic in the UK. And I want to talk about diversity within the LGBTQIA plus populations as well. So I've just been talking about some sort of common broad experiences and coping capacities, but of course, those are not the same for every individual. There is no singular LGBTQIA plus experience. This study highlighted vast diversity among LGBT plus populations with important differences between, in particular, cisgender and transgender lives, unique experiences among older LGBT plus people, those with disabilities, and those of particular race, cultural and faith groups, as we saw with the LGBT Muslim support groups. Now, if we overlook diversity and only account for the most visible experiences, we risk furthering inequalities within minority groups. And McKinnon and others talk about that in the context of media reporting, whereby often white gay male voices are centered as representing all LGBT plus people, which is problematic for many reasons. But just as feminist activism scholarship highlighted the interconnectedness and widening scope of access of oppression for women through the lens of Black women, racism, sexism, and class, and then later intersectionality, disaster scholarship and practice needs to look beyond singular or binary approaches, for example, cis-white heteronormative versus other, and incorporate the complexity of multiple intersecting factors of marginalisation. If a singular focus on liberation from structural racism is a goal, then Black women remain oppressed through structural sexism and reproduction of the patriarchy. Similarly, if a singular focus on liberation from homophobic oppression is a goal, then many members of LGBTQIA plus populations remain oppressed through other forms of structural and systemic social inequalities. We also risk furthering divides within LGBT plus populations if we seek to address vulnerability and marginalisation of LGBT plus people only through a traditional cis-white heteronormative frame then. So this is because those most conforming to and already benefiting from existing power and societal structures stand to profit the most, such as white males, those who can and choose to get married, and those with cisgender identities. Now, much disaster policy and practice, including COVID responses, adopts a normative framing of gender and sexuality, largely engaging with male-female gender binary and heterosexuality as the norm. Several authors have called for a move beyond white, binary, cisgender, and heterosexual Western norms in understanding and reducing LGBT plus disaster vulnerabilities. But to address LGBT plus marginality effectively, the assumed naturalness of cisgender and heterosexuality must be interrogated as socially and systematically constructed, something which still does not happen in disaster management policy and practice. Moving beyond cis-white heteronormative analyses in disaster management and research can hopefully lead to analytical framings that accommodate diverse and intersectional identities and needs rather than trying to make them fit within a system that was largely built to neglect and exclude. And we see that experiences of LGBT plus people are directly linked to pre-existing socio-political marginalisation and economic inequalities, including within LGBT plus populations. For example, it was already known in the UK that LGBT plus people, especially transgender people, experienced higher rates of mental health challenges and difficulty in accessing healthcare, indicating causes that predate the pandemic. Yet, these issues were not adequately planned for in official crisis responses. Further, interviews revealed cases of transgender people experiencing aspects of lockdowns as positive, giving them a reprieve from the pressures and marginalisation of being trans in normal life, such as transphobia and public scrutiny of trans bodies. And these deeper issues need longer-term solutions beyond COVID-19, of course. But these experiences born from marginality remind us that we must look beyond identifying who is vulnerable in moments of crisis and short-term services, which might address some needs, and instead examine the root causes and how dominant structures and approaches in society work to exclude and marginalize in normal times. Even the key roles of LGBT plus community groups in supporting coping capacities, which I just talked about as being really important during the pandemic, echo pre-pandemic needs and activities. So such groups developed in normal times due to existing gaps in services and exclusion from mainstream society, with LGBT plus people often developing their own supportive and safe spaces. So what we saw in the pandemic was in principle largely the same groups doing what they have always done to support each other in the absence of adequate inclusion in society and public policies. But these statements on pre-existing marginalisation and vulnerabilities are nothing that disaster vulnerability theory doesn't already tell us and has been telling us for decades. So then why are LGBT plus needs still largely absent from crisis policies, given we should be able to predict these existing issues will be exacerbated? Even international frameworks aimed squarely at building resilience capacities for the most socio-economically vulnerable groups in societies fail to adequately include LGBT plus populations, such as the Sendai Framework, Disastrous Reduction, and the Sustainable Development Goals. I think one key factor is that social vulnerability approaches, which are adopted in disaster policy and practice, often problematically assign the label of vulnerable to communities based on demographics, for example, based on class, gender, race, and so on, which then serve as measures of vulnerability without incorporating community knowledge on how vulnerability looks or how it feels to those who experience it, or critical assessment of the oppressive structures and processes that create marginality, as Viola Jacobs has written about. If marginality is not inherent to individuals, but produced through societal and political processes that increase disadvantage and exclusion, then the structures and conditions of privilege and the role of those advantaged by power in dominant oppressive structures must also be critiqued. And so then for activism, change and inclusion for minorities in crisis planning and public policies, oppressive structures need to be named as such, enabling movement past labeling gender and sexuality or race, class, as vulnerability indicators and towards addressing structural factors of cis-heteronormativity and heterosexism or racism, classism, ableism, whatever else it may be. And so then to finish on some recommendations arising from both the study itself and also my kind of further thinking about how we can build on this into the future. To improve policies for LGBT plus people, in the short term, policies for crisis responses and planning should prioritize access to disrupted services that were directly related to the aspects of LGBT plus vulnerability most exacerbated during the COVID lockdowns. So in particular, mental health support and transgender healthcare access. To better incorporate LGBT plus diversity, education on the lives of gender and sexual minorities should be included as part of workplace training programs for government and crisis management organizations. And LGBT plus councils and advisory boards should be strengthened. Co-production of policies should be a goal, involving communities and harnessing community wisdom. Productive dialogue with LGBT people themselves and the groups and organizations that represent them is essential for developing inclusive and efficient strategies, as LGBT plus people themselves have the best knowledge and understanding about LGBT plus lives to inform what is needed and will be most effective and appropriate care and support. I suggest developing an international standard on LGBT plus inclusive crisis responses and risk reduction will aid in preventing exacerbation of existing and creation of new inequalities during crises. An international standard is necessary to address common structural and cross-national causes of marginalisation and uneven crisis experiences. And for longer-term change, policies cannot continue being based on assumptions that populations are cisgender and heterosexual. They must not only include and account for LGBT plus needs and capacities, but must recognise diversity within minority populations. And then in terms of further research, this research focused on the first wave of the pandemic in 2020, but longer term or reflective studies traversing the changing stages of the pandemic and associated responses across the world will likely expound different and further unique challenges and coping strategies of LGBT plus people. This might include examination of experiences of later waves of the crisis, but also potential lingering impacts in the coming years. For example, how do LGBT plus communities rebuild their social lives after extended periods of isolation? Beyond COVID, further research is needed on LGBT plus experiences of crisis generally, with larger and more diverse participant samples, particularly focusing on less visible minorities within LGBTQIA+, such as non-binary, intersex, or asexual people. And to more fully comprehend the marginality and resilience of gender and sexual minorities, studies must more acutely examine the intersections of gender and sexuality with other identity characteristics and axes of oppression. And researchers must not only investigate experiences of those deemed vulnerable, but critically examine the structures of privilege that guide crisis management, aiming to address barriers to greater equality, diversity, and inclusion for minority groups within government organisations and disaster practitioner organisations, but also broader social and health services and crisis policies. And so to finish then, moving forward, researchers, policymakers, and practitioners must shift focus away from crisis response towards risk reduction. If we were more prepared and marginalised sectors of society were better supported, we would see less severe impacts, as disaster studies have informed for a long time. We must work now to address the political, economic, and social structures that constitute root causes of vulnerabilities to mitigate against future hazards, pandemic or otherwise. LGBTQIA plus inclusion in crisis planning and response requires longer-term attention beyond the immediate challenges of COVID-19 and a radical redefining of the status quo through working to recognise and resist cis-heteronormative systems that create and reproduce inequalities, rather than just addressing short-term needs. And there's a lot of stuff there that you probably won't read, but if you want to, you could make a very fast note. And that's it for me. So thank you very much. And I'm going to move swiftly on to Jack Lopez.
Hi, can you hear me okay?
Yeah.
Good. I'm getting serious now. I've put my glasses on. Thanks for coming this afternoon, everyone. And I think there's a really nice segue there from the way that Billy finished on his recommendations, actually, and talking about the longer term implications and the different kind of waves that we've gone through. And what I'm going to do with my paper this afternoon is highlight the key challenges faced by trans, non-binary and gender diverse adults on NHS gender identity clinic, private healthcare and GP pathways of transition related care, and in an extension, as happens with research when you're behind in writing up your original results, other things happen. The pandemic continues, and my research ended up getting extended into the second lockdown that we had in the UK, which managed to start to reveal a lot more things for me very much around these ideas and points that Billy was discussing around the use of peer-to-peer support networks and how useful they were in the initial stages of the pandemic. And what I found as my research has gone on, is it's interesting to see how the broader social implications of a pandemic impact on peer-to-peer support networks in the long term, and how they become actually more vulnerable the longer that a crisis occurs. So initially I'm going to go through some language stuff and not too much. This isn't a lecture on trans healthcare and who trans and non-binary people are, but there will be some terminology that I'll explain, just so you can kind of keep up with the language that I'm using. But initially, the core impacts of at least the beginning and the first 12 months of the pandemic for trans healthcare in the UK is that gender identity clinics, so that's gender identity clinics are the NHS pathway to transition related healthcare, the public sector. Wait times across the country, kind of according to the data that we've got, have increased significantly to in between 36 months and 5 years from the point of referral from a GP. So this is where we were at a point pre-pandemic that wait times for trans-related healthcare were around 2 to 3 years, 4 years maximum. For some public health services, we're now between 5 and 7 years from the point of referral for when you can get through the door and speak to somebody. In terms of a timeline for addressing cancelled gender affirming surgeries, it's now estimated to be around 3 to 6 years in order to be able to catch up with delayed. And for people who have yet to be referred for surgery, there's an endless timeline of when that could possibly happen. This is actually, these are the highlights of that I'm going to kind of break down and talk about in more detail. Essentially what has happened, and it's really important to keep hold of this, when we read a lot of stuff about the extension in the waiting periods. Oh, I haven't even shared my screen though. I just realized I'm going to do that now. There we go. Too busy, too excited to talk. This is the thing. Right, okay. There we go. That's better. This makes sense now that you know the title of my talk is on waiting. It's on interruptions to access to gender-related healthcare. The point that I was making is while we can get very lost and worried about the extent within which wait times have extended during the pandemic to years. I mean, I think one organisation I work with on part of their health strategy board, Asexual UK, I think we crunched some numbers, or it might have even been gendered intelligence, that we came to the point that if somebody was to go to their GP to ask to be referred to NHS gender services at this point, it would probably take up to 24 years for them to complete a full transition. That's the state we're in now. However, some of that is also because the benefits that have happened around the pandemic, around people not being able to work, being locked down and being under stress in other ways, there's actually been an increase in referrals as well. For people that have decided to transition, because they've actually hit a point in their life where they've had time to stop and think about who they are and what they truly want. So the increase of pressure on the services is to do with the fact that it was already broken in the first place. And there's also been an increase in referrals because people have had time to think about it. So though the pandemic had a multifaceted impact on LGBTQ+ people all over the UK and the world, an additional factor for trans and gender diverse people who seek medical transition was access to transition-related healthcare. And this was a significant part of the pandemic experience for most trans people who are part of the healthcare system. So now there were many social advantages and disadvantages, as I've just mentioned, to being trans and LGBTQ+ in a high income country during a pandemic, you know, and I really want to focus on the fact that what I'm talking about in the UK context is we're talking about the conditions of people within a high income country, and there are different levels of privilege within that, dependent on who they are as well. But there can be a lot to be learned from how time and space can support people with gender incongruence to discover a path to liberation and also find their community, which is some of the things that Billy adhered to in his presentation. Now, the most significant focus, and I will declare my bias here as a barriers to healthcare researcher, but the most significant focus for me is actually how a failing health system, an existing failing health system, and its patients fare in the context of a global public health crisis. And moreover, A, what lessons can be learned from this, and B, what is it actually like trying to live through it? So I'd probably be here for about an hour if I was trying to pick through the social context through which trans and gender diverse people were existing pre, during and ongoing phases of the COVID-19 pandemic. But you'll be very pleased to know that I am not going to try and do that in 20 minutes. But what I am going to do is discuss the core findings of my research, the recommendations that I've drawn. But I also want to spend a little bit of time to share my thoughts on how crisis events can also be used to obscure existing systemic failures and manipulate trauma states of mind to feel helpless in the face of adversity. And this is the point that adheres to the longevity of my research so far and how I've started to see peer-to-peer support networks change and relationships with people change as the panic has wore on. So from here on within, what I'm going to do is refer to trans, non-binary and gender diverse people under the umbrella terms of trans, just for practicalities and for the context of discussing healthcare as well. Because regardless of how a person personally identifies in terms of their gender identity, they come under the definition of trans as a trans person in order to access transition-related healthcare. So for the context, it's important to know a little bit about where trans healthcare was before the pandemic hit, as to understand why it's been so significantly affected. So what I'm describing here is the NHS pathway as well, not the private pathways. So as you may be aware, trans people are very much more likely to have existing poor health outcomes and face barriers to healthcare in normal circumstances and normal conditions. Trans people in the UK, whilst privileged in numerous respects, so for example, we will live and we will be expected to live beyond the age of 35 years old, which is the estimated mortality, particularly for trans women of colour across the Americas, particularly in Latin America and particularly in Brazil as well. We're also not at risk of being imprisoned or murdered for merely existing. We do, however, face huge challenges in terms of accessing gender affirming transition healthcare and are at the mercy of the mass media currently, apparently, according to the BBC as well, in a UK context that like to kind of demonise who we are in the view of the public. So trans people at the intersection of multiple forms of marginalisation, including trans people of colour, chronically ill trans people, disabled people, elderly trans people, and trans people who are asylum seekers, homeless or sex workers, suffer even high morbidity and mortality risk, particularly in a UK context. So despite evidence to the contrary, and all this talk of waiting lists, the UK NHS transition-related health provision on paper actually looks pretty acceptable. However, in practice, this isn't quite the case. So what we've got here on the slide is the Gender Identity Service Protocol. This is how things work in the NHS, and this is how things should work in a utopian, idealistic world. You go to your GP, you ask for a referral to a gender identity clinic. You access the gender identity clinic, and on your first assessment, you have an appointment. You then have to have a second appointment in order to have two assessments to be diagnosed as being gender incongruent, although the NHS is still using very backwards language in terms of its diagnosis and going against what the World Health Organization and what WPATH also recommend. But following from your diagnosis, you have an agreed individual care plan. You then continue to see a consultant at the GIC. You get a further two assessments and a recommendation if you are transmasculine or non-binary and you want HRT and top surgeries, if you are a trans woman or non-binary femme, in order to get HRT and also access hair reduction services as well. Following on from your surgery, you are either at that point discharged back to your GP, or if you want to move on to have other types of surgeries and other types of gender affirming surgeries, and here I'm referring to lower surgeries, you have to go through another 2 assessments and also get a referral for a gender recognition certificate if you want to do that anyway. You don't have to have a GRC to have surgery. You don't have to have had surgery to get a GRC. But as you can see there, there's supposedly a very straightforward protocol. Now, the lived reality is very, very different. Essentially, when you first go to your GP, you are at risk of either them gatekeeping or them being perfectly fine and open. Some GPs are happy to refer straight away. Other GPs, dependent on their own subjectivity, will often refuse to refer for quite a while. And lots of people have had large fights on their hands even to get a referral. We're not currently in a state where people can self-refer to a gender identity clinic. That should be the case. It is the case on paper. However, most gender identity clinics do not have the capacity, because there's only 7 of them in the whole of the UK, to accept people on self-referral. Your first assessment is actually a telephone assessment, and it's on a strict exclusion criteria. So you won't receive any form of diagnosis. You'll get a telephone conversation off a nurse, and this is in order to keep within the NHS timeline of being seen to within a specific amount of time. The number's gone out of my head at the moment, but essentially you'll have a telephone assessment that requires yes or no answers to questions. It's wholly focused on what surgery you would like, and you have a fear that if you say no at any point, that you'll be rejected and you'll have to go back to square one. Essentially, after you've had that initial telephone assessment, you've got a 2 to 5 year wait in order to be seen for your first appointment, where they may or may not discuss having a diagnosis with you. There is a narrow pathway based upon a medical binary transition. So depending where you get sent to, it's very difficult to be within the NHS system and be a gender fluid, non-binary person that also wants to access transition-related healthcare. And a lot of non-binary and gender fluid people have to adopt a binary language in order to kind of get through all the different doors that they want. So it's really not, it's very much on an old-fashioned A to B binary system. It's time sensitive in terms of when you get your referrals for operations. If anything happens in the meantime, if you have any health issues, if you can't find the right surgeon, essentially your referral runs out and you have to go back to the beginning again and get a different referral. The wait lists are very dependent on who you are. The NHS system itself is incredibly, in terms of whether or not you can have surgery, it's incredibly fat phobic, it is ableist, and it is also racialized in its bias. And this is related to the fat phobia as well. It insists on a particular level of BMI and weight in order to have forms of surgery, and it doesn't take into account people of different ethnic and cultural backgrounds that tend to have a higher BMI than others, and therefore we get questions around medical racism within that, and people are forced to go on diets a lot of the time in order to be able to access surgery. This is highly problematic because lots of people within the trans community have pre-existing mental health issues and eating disorders due to the stress of growing up as a trans and non-binary person, and this encourages the likelihood of somebody having an eating disorder as well. So just finally, lots of GICs completely discharge a person if they're not going to have lower surgery. So this means once a person is discharged from a GIC, it's very difficult to get healthcare from them in the future. So that's essentially a breakdown of what should happen and what is the lived reality. These are the circumstances that we had with trans healthcare before a pandemic hit. Now, just briefly for context, in terms of the study that I did, It involved an ethnographic analysis of peer support groups on public forums on social media. I could do a whole different presentation on the difficulties of doing ethnography of social media between public and private groups, but that's for another time. I also did semi-structured interviews with adults in receipt of transition-related healthcare. So the participants that I recruited were very specifically people over the age of 18 who were already or waiting for transition-related healthcare. Now, the uses of social media can be interwoven with the qualities, political structures and histories of localities and regions. So therefore, it was really important for me in terms of my social media analysis only to focus on trans adults within the UK only. And this is part of a process of creating, as an anthropologist, an online ethnographic place, which is constituted through emergent relations between things and processes. The social media ethnographic trans space can be described, I think, as clusters and intensities of things, which are both localities and socialities as part of their elements. Many trans and non-binary adults throughout the UK live isolated from LGBTQ communities, particularly those people in Scotland, Wales and Northern Ireland, because people in Scotland, Wales and Northern Ireland have to travel to England for any kind of surgical intervention. The online support groups are very vital as a place of information sharing and peer support, and this has only increased during the pandemic. So the interviews and social media analysis focused on three main topics, which are there as the objectives on the slide. Overall, I did 10 interviews between June 2020 and January 2021, each lasting an hour. And then I did a further 4 interviews later on this year, specifically with trans men who were affected by the cancellation of lower surgery provision. And that's something I'm going to talk about in more detail. Now, there were a lot of there were limitations in terms of geographic location and ethnic diversity in terms of my interviews. But however, they were still highly valuable for insights into border crossing transition related healthcare. So I spoke to a percentage of the people that I spoke to were based in Scotland and in Wales, and it was possible for me to be able to understand a bit more then about the pressures on people that are out of England in terms of their access to healthcare. So, experiences from the interviews. So responses from the first round of interviews. So these were reflecting on the first 6 months of lockdown. These were mixed, and they were very much dependent on the amount of years in the system and access to private healthcare as well. There was less interruptions in private services during the pandemic, and some surgeries, private surgeries, were only delayed by a matter of weeks rather than months. Public health surgeries only started to happen again round about this summer, actually. So that there was the difference. Private surgeries were happening in 2020. Public surgeries only started a matter of months ago in 2021. So the study revealed a lot about people's coping strategies. It revealed a lot about the pros and cons of a break from being publicly trans. Some people with additional support needs also found telephone appointments and access to GP and community nurses much less stressful during lockdowns. Others found it a major cause of concern. So the longer the lockdowns endured, the more participants struggled with affirming their identity and finding their community. So there's a lot of things kind of fit in here with similar to what Billy found in their study. Essentially, it was a mixed bag, and it changed during this time. So initially, although people enjoyed the fact that they almost didn't have to try as much, they didn't have to leave the house, so they weren't worrying about the way that they were being perceived and so forth. This actually became more difficult the longer that lockdown went on. In terms of actual access to healthcare for people who were already on the transition pathway, already on hormone replacement therapy, that focus wasn't affected too much by the pandemic. There was an initial panic online about people having access to healthcare, having access to hormones, but this was also due to the combination of Brexit happening around that time as well. There was an initial panic about shortage, reportedly from other researchers, I have spoken to, and from what I've seen online, there was a bit of a rush of people starting to source hormones illegally in order so that they were worried that they couldn't access them, but there wasn't so much of an impact there. So the core key challenges in terms of the first 6 to 12 months at least was in terms of access to transition-related healthcare services. All participants that I interviewed were on NHS gender identity clinic pathways. They were also using a mix of private healthcare and GP pathways of transition-related care. So peer support networks on social media demonstrated a high level of panic, like I said, in terms of people worrying about access to hormones. Interviewees were already on established pathways of care, and with good GP relationships were actually able to access their hormones without problems. They were able to go to surgeries for injections. Now, these patients with more than two years or more of transition-related healthcare are so accustomed to micromanaging healthcare provider relationships, plus their own health regimes, interruption to hormone therapy was actually very minimal. So what you've got here is people who are established on a pathway are so used to the system being so rubbish. They're so used to managing their own healthcare that actually they were less affected by what was going on in the pandemic in terms of their healthcare. The issue was around people who were at the very beginning and trying to access, having no information and no communication whatsoever in terms of what would happen, because gender identity clinics essentially shut down overnight and provided no communication whatsoever to any of the patients. So there was postponement in terms of gender affirming surgeries. This is the thing that was most impacted. So in March 2020, all planned surgeries in the UK were cancelled due to COVID-19 restrictions and availability of workforce resources. Though trans patients are definitely not alone in having long awaited surgeries cancelled indefinitely, the longer term impact on mental health, suicide risk and quality of life is significant. Plastic surgery was amongst the most impacted in 2020 of all the types of surgeries across all areas of health and trauma care. Not all gender affirming surgeries on the NHS are funded, and this creates anxiety over what can be obtained by men, women and non-binary people. Interviewees were at very different stages of surgical transition, and this made a difference in terms of how they felt about the further postponement. Transmasculine people in particular face the longest wait times for chest reconstruction surgeries on the NHS, and this can take anything from 3 to 6 years from the point of GP referral to GIC, as I've already said. Gender affirming surgeries require time to recover, planned absence from employment, impacting on whether you can start your life again. And interviewees noted a number of years that their life had already been put on hold whilst waiting for surgeries, and this was only being increased by the pandemic. So these are people who were putting off going to university, starting their careers, having relationships, moving house, all of which they'd kind of tried to imagine this will happen in the next couple of years, and that was completely taken out of their hands. So private planned surgeries suffered minor delays, and these were quickly reorganised. And what this does is it exacerbates the divide between people who can access private care and those who cannot. And clearly, as we'd understand it, within the UK context, those that can access private care are fewer in numbers than those that are reliant on the public healthcare system. It's also important to note that it's exactly the same surgeons that provide the surgery for NHS or private care. It's the same people. So this is really difficult for people to think about. It also changes in terms of when I talked about racism in medical models and fat phobia and ableism. The criteria for having surgery under the private system is very different to the public system, and there's different measurement levels. So somebody with a BMI that's assessed as too high in the NHS system can generally get surgery privately without any problem whatsoever, but they're dependent on having the resources to do so. There was a large problem with communication. Core communication was fragmentation and disparity, in which gender identity clinics remained on some level of provision, whilst others had none. Interviewees reported that some GICs initially failed to inform patients and their appointments had been postponed, which caused great anxiety and confusion. There was nowhere to phone, there was nobody to email, email, there was nobody to speak to. People were completely left alone. And therefore, what we do is we have this over-reliance on peer support networks where people are desperate to find out. But what you also have is misinformation and gatekeeping happening within the peer support networks as well, which I shall talk about in a bit more detail soon. So in terms of the public and private healthcare divide, the pandemic brought to light a very unequal divide between those able to access public and private healthcare. Reflecting the broader trans community, participants over the age of 35 with established careers and younger people with strong family support networks are more likely to be able to pay for private gender clinics. During the pandemic, however, there was a definite significant rise in crowdfunding initiatives for individuals, and online discussion on navigating private providers increased in comparison to before the pandemic. So online, you would always see discussion about people swapping details on private access to care, who's the best person to go to, how much does it cost? And this increased tenfold during the pandemic. And I think this is a sign of the anxiety and panic that people had of absolutely not being able to see whenever they would ever be able to access public healthcare again. And what this does is it leads to people wondering about, getting into debt, getting bank loans, borrowing money, doing all kinds of things in order to be able to access that private healthcare. Now, something that we had later on, in May 2021, trans male patients on lower surgery referral pathways were informed that the sole provider in the UK were no longer able to carry out surgeries. So the lower surgery team had been unable to secure a hospital site from which to carry out procedures, and therefore they were no longer able to honour the NHS England contract, and the contract was withdrawn. This cancellation happening within the broader context of gender identity clinics on reduced capacity, all NHS gender affirming surgeries postponed, and a mass increase in wait lists and increased dependence on GPs for non-specialist care could be considered as unforeseen consequence of the COVID-19 pandemic. And at first it was kind of given across as, oh, it's because of COVID. So this development at the time in my research shows how the initial positives of online peer support actually became more fractious as the pandemic wore on, and trans health inequalities actually worsened. So the initial months of COVID restrictions and lockdowns provided a mixture of reprieve and trauma for trans adults in the UK, all of which were dependent on intersecting socio-demographic factors and personal support networks. As my research continued, there were very specific cracks in the surgery system for trans men, appearing that only really came to light precisely because of the reliance on peer-to-peer networks and that replaced the paucity in health service communication. So as I'll explain in a moment, the events leading up to the complete cancellation and abandonment of transmascular lower surgeries were a pre-existing problem, which were obscured in detail by the pandemic, and B, actually the straw that broke the camel's back for the limits of peer-to-peer support online. So the timeline here shown on the slide notes the key dates during the first 18 months of the pandemic, from the postponement of all surgeries to temporarily resumed for some, and the contradictory communications between the NHS Gender Dysphoria National Referral Support Service, it's a very catchy title, patients and contract provider. So in brief, and to add some further details, transmasculine lower surgery patients at whatever point in their pathway assumed that, as with all NHS surgeries, everything was indefinitely postponed due to COVID-19. However, by August 2020, a handful of stage 1 phalloplasty surgeries. So phalloplasty is when a penis is created, and it's a surgery that happens in 3 stages. So a handful of stage 1 phalloplasty surgeries had taken place in London. So bearing in mind that during this time, there were existing mid-stage patients around the UK who were not being offered any treatment at all. These are patients that had had stage 1 or stage 2 surgeries earlier on, pre-pandemic, who had health conditions and complications and weren't being offered any support at all. Yet a handful of new operations happened around that time. The handful of stage 1 operations that happened in between August and September were explained to those patients as a pilot. a pilot only for men in the London area. And they were actually asked by the surgery team not to discuss this publicly. They were offered surgery and asked not to speak about it on social media. The operations occurred and men were sent home to recover with a basic package of post-surgery care from the hospital team. As soon as they had begun, in September 2020, all operations and aftercare ceased completely, along with all direct communications between patients and providers. So we had a gap between August and September where a handful of discrete operations happened. People were sent home, and it usually takes 3 to 4 months to begin proper recovery from this. However, within a month of those surgeries happening, all communication and all post-surgery support was removed. So by this time, the community was so used to the indefinite pausing of treatment for COVID and the poor communications, they were left to assume that this was the case again. It was because there'd been a rise in COVID and everything would get better eventually. When other types of gender affirming surgeries for trans men and trans women started up around the end of 2020, this would be around top surgeries and other things, there was still no word or communication from lower surgery providers, and people began to question why, by which point the few who had surgery had withdrawn completely from social support networks due to conflict. By May 2021, a post appeared on social media saying that the GIC had informed an individual that no further referrals were being made for lower surgery as there was no longer a provider in the UK. This news understandably sent the online community into a panic, and days of rebuttal, investigation and panic phone call providers followed. By June 2021, the rumours and conversations online could no longer be contained, and the NHS referral service finally wrote to some patients to officially state that the providers no longer held the NHS contract and that it was going to be put out to tender. The letter indicated that a new provider would be found shortly after July, and that in the meantime, patients should contact their gender clinic or GP for mental health support. Nothing about mid-stage complication patients or post-operative care for recent patients at all was mentioned. So due to the ongoing pandemic, there was very little that gender clinics or GPs could offer in a way of support, and they weren't even aware that it had happened. So just kind of finishing up really around this as well, as you can observe from the quotes here on the slide, patients were vulnerable. They were made vulnerable by brief access and then the removal of lower surgery in its initial stages. And then they were further isolated from the peer community, which was set up initially as a form of mutual support in the face of weak and unsupportive systems. One common theme amongst interviewees was the fear and frustration of having nowhere to go to complain about poor treatment. With only one team providing lower surgeries in the UK, the transmasculine community being so small, people felt easily identifiable, and the historical gatekeeping that makes community life, that makes a community live in a care removal anxiety. People feel abandoned, trapped, fearful, that if they openly complained, they would be treated poorly or they'd be refused surgery. With nowhere to go and in a time of crisis, peer-to-peer support actually reached its limits. This is not the fault of the trans community. This is the cause of circumstance that leaves a community weak in the face of resistance. It is political circumstance and over-governance of healthcare ultimately resulting in a divide and rule situation, one that resolves nothing for the health and well-being of a vulnerable population. It's not an uncommon narrative in the examination of crisis impacts on unequal societies. It is, however, not so common to turn this analysis on a high-income country like the UK that is presumed to be more equal than others. In the context of a high-income country at least, it's an indication that these new kind of public health emergencies reveal more about pre-existing inequalities that have been previously ignored. And the question being, however, is what will it take to continue the challenge of health inequalities and discrimination in high-income countries beyond this snapshot of a pandemic? So the worry that I consistently have as a researcher is that so much of what has happened here is going to be forgotten in the rush to get out of the pandemic. So just kind of finishing up here, in terms of recommendations of what I've been finding so far, is we definitely need further research into peer-to-peer online support networks in terms of the pros and cons. They're incredibly positive, but when they're in the context of an incredibly broken health system, they can also be very damaging. They mirror the types of gatekeeping that actually happen in the health service themselves. You'll have particular admin people that run peer-to-peer support networks online, and they will gatekeep who they allow in those spaces, and they will also remove people from those spaces. Lessons need to be learned during the initial year of a pandemic, and these shouldn't be lost in the recovery process, as I've said. There most definitely needs to be an independent review of gender identity clinics in the UK and referral pathways. We are at breaking point and we can no longer continue the way that we are. More training and support for GPs to manage non-specialist transition-related healthcare needs to happen. So much could have been avoided in terms of the increase in wait times if GPs were just capacitated to deal with non-surgical related issues of trans-related healthcare. And there also needs to be countrywide clarity and agreement on shared care options as well. So this is between private and public healthcare that a lot of GPs don't have the information about to support. So I've said a lot, I've given a lot of information there. I'm going to be quiet now, and if anything's come up for you, please note some questions down, and hopefully we can cover that in the Q&A.
Okay, thank you, Jack. Yeah, really interesting to see some of those broader structural issues, down to a kind of finer scale for a particular population group accessing a particular type of healthcare, reflecting much bigger problems. Okay, so let's move on to Luan. It's going to talk about research in Brazil for LGBT plus people during COVID. Thanks, Luan.
Thanks, Billy. Hi, everyone. I'm really glad to be here today. So I'm Luan Casal. I'm a research assistant for the project. I have been working with Billy through this year, focusing especially in data from Brazil. I'm a PhD researcher in education. I'm also a Brazilian psychologist and a queer activist. So I'm discussing here data that's related to my community, the community that I belong, and my previous experience with research. I just would like to acknowledge the support that we received from HCRI and the HCRI admin staff, here represented by Sam. Also, the other people working in this project, Tiago Muniz, who did the interviews, and Paola Eiras, who did translations to English. And I would try to skip some discussions, just bring some points because of the time. When we are discussing Brazil, I think it's important to highlight that we have high levels of violence against LGBTIQ plus people, worsened since the extreme right victory in federal elections in 2018. However, we also have very strong and resilient LGBT plus movements since at least the military dictatorship between 64 and 85. They have creating a series of strategies for resisting state violence in the first place, but also improving LGBT rights in the country, and which led to very original and changing public policies for LGBT people in Brazil. At the same time, the country was badly hit by the COVID-19 pandemic. We have now more than 600,000 registered deaths so far. So combined with conflicts and contradictions with federal government's negationist position, which perhaps you have been seeing on the news. This project worked with LGBT people from UK and Brazil. In Brazil, we had 12 interviews. It's a small group and it's not representative. It's important to consider that we were working from the UK in the beginning of the pandemic with several restrictions who we could access there in an online setting. So there is also a record of class very clearly who could access this research for answering. And you can see that from these 12 online interviews, we had mostly cisgender people. We thought that it was important even so to keep discussions about trans people, because we have recently seen certain positions in LGBT movements, or better, the LGB movements, LGB alliance, who try to exclude trans people from discussions and public policies. And there is also some tries to reproduce that in Brazil, and we thought that it's important at least to highlight that our participants, they are not representative of all experience, but at least we can bring some thoughts on LGBT experiences during the pandemic. And our interviews were focused in 2 states, São Paulo and Rio de Janeiro. They are both in southeast of the country, more industrialized area. There are some specific consequences of that we will discuss later. But this is not showing a portrait of whole Brazil or properly representative, but at least we want to bring what we could feel that had connections with experience in the UK, and also other reports and broader research. First of all, our participants, they were describing the effects of lockdown in terms of changing their arrangements for living, poor and worsening mental health. People who have had problems before, they were worsened or new symptoms appeared. Suspension and delay of health and social care treatment and services, especially those who weren't related to COVID. And the close of grassroots and community-based LGBTQIA+ space with no alternative provision. So there is something that the lockdowns were imposed in March. However, they were not followed by plans, alternative plans for offering support, social care, health care for those populations. This is not the same as being against lockdowns. It's saying that when we impose those policies, it's important to follow with other complementary and alternative policies. With that, and as Billy also showed in the UK, many services were disrupted, and many community-based groups had to stop their activities until they could change in online settings, but even so many times they couldn't have enough funding for that. So Laura and Ursula, they bring issues about these disruptions. Laura, who couldn't go to LGBT spaces, focused spaces, which were at the same time social spaces, but political and activism space. And Ursula tells about her health treatment. She had to stop it in public health service because she couldn't get an appointment for face-to-face consultation, since this wasn't a COVID-related issue. Also, we had this course of fear and suspiciousness in Brazil as a federation. We had different policies and decisions from federal, state, and municipality levels, many times contradictory, and the federal government had to decide to create even more conflict between these parts instead of organizing the system. So each person would receive different instructions and recommendations where they lived, from local authority, state level authority, and federal authority. What do you do when that happens? Also, this was a general problem in Brazil. That's not specific about LGBT plus population. However, the federal government was also promoting discourse, anti-LGBT discourse and practice, and promoting prejudice on their and discrimination on their discourses, either the president or some ministries. So we could see that participants were already suspicious about anything that came from the federal government, even when they were specific interesting recommendations in terms of healthcare or testing. they were suspicious of that because it's the same government that had LGBT phobic positions. So we have also we had pseudoscientific discourse and practice from the federal government promoting medicines that do not help against COVID and promoting as a solution. These contradictions or this chaos produced even more fear and suspiciousness about the government, which should offer healthcare and social care, and each other. So, left to make individual decisions on COVID-19, there was no proper guidelines to follow, while in the UK you have very restrictive guidelines, especially during the lockdowns. Participants were telling us about unstable and contradictory practices, that they would take different decisions in different contexts, even trying to follow a certain line of thoughts, but couldn't get that right exactly because either they haven't had enough guidelines for that, or they wouldn't think about that. A general feeling of worry and fear. At the same time, they wouldn't have their usual coping strategies for dealing with anxiety or fear in general, and a feeling that the past history of LGBT plus community segregation was coming back, especially involving experiences with HIV and AIDS. And at the same time, we had very important responses from LGBT plus communities and grassroots movements, trying to understand inequalities and inequities. And it was really interesting how many people stressed. Well, we interviewed people mostly with some kind of income, but they stressed, they worry about LGBT people who couldn't have income or safe jobs. So they stress inequities based on race, social class, gender, but also cross it with other conditions such as care roles and labor conditions. While half tells about huge problems for accessing health exams, Mauro tells us about his position as a carer, as a father of three, and he had to take care of all dynamics at home. While Laura is connecting racism and gender discrimination and inequities in this experience during the pandemic. If experiences are not the same, we consider that people share some structural inequities in terms of gender, sexuality, and body characteristics, and we don't see as essence of people. LGBT identities, they are not necessarily an essence in each, and they are not at all an essence in each person, but they are structural effects of those inequities based on gender and sexuality. And some specific markers, they change completely this experience in terms of race, class, care, and location, which also change their possibility to access specialized services. And on that, it's important to understand that in Brazil, and especially in Rio and São Paulo, you have some LGBT social care services funded and administered by the state or either local authority or state authority. And so you have public services and not based in charities necessarily, which offer some kind of social care, especially for people from the private backgrounds. And those services were suspended because of the lockdowns. They were not considered at time, or most of them were not considered at time an essential service to keep open. So Rafa was worried about the increase of lethal crimes during this time, especially for those more exposed homeless people, sex workers, in tough situations. And while Bruno was concerned about keeping services open, some of them, they were funded by the government, but Bruno also stress about Casa 1, which is an activist-based service offering sheltering and housing. So we could see at the same time that they were worried about those services and people accessing service and protection. They tell us about the interruption of services or when they were open. So Rafa tells about an LGBT center which was closed, but when they were open, like Ursula tells us, some people the staff was exposed to the pandemic. So LGBT plus staff working in an LGBT public center were exposed to pandemic and die in consequence of their exposure at work. So we also, even if on the one hand, we have to think about why the services are closed and how to keep them open, but on the other hand, how to do that safely in terms of, otherwise we are pushing our community, LGBT community, to exposure and harm. So despite the achievements during past decades, we lost some of the specialized service, at least temporarily during the lockdowns, leaving behind some of the people who were more hit by the pandemic. So what we could see in interviews in Brazil, participants told us about their financial, employment, and housing securities and the consequent effects on mental health, which was also found in different large-scale or international reports. These disruptions to LGBTIQ plus community-based activities and public centers, they reduce the access to rights, they reinforce isolation, but they are not necessarily something new. They are closed many times during the past years or reduced in terms of capacity because of crisis, local crisis, either health crisis, violence, and financial crisis. Also, that structural inequities have been stressed during this crisis, especially in terms of LGBT people, and the discourse of fear, they justify, legitimate, and multiply episodes of discrimination and even lethal violence against this community. So exactly all those discourse about fear and government discriminatory discourse and practice, they support and reinforce practices of acts of violence against this population. It's, as Billy already said, it's important in-depth studies on LGBTIQ plus people's experience, especially with more diverse study samples, and the Grupo Conexão G is working on a project much more grassroots based. Maria can tell us more about that. We are also trying to connect Brazilian scholarship to the British context and the Anglophonic academic literature, and how we can contribute to studies of disasters and its material and subjective effects on LGBTIQ plus community. In terms of recommendations, specifically for Brazil, we are concerned about including the protection of LGBT plus community in general and specific response to crisis. But we must consider direct participation of those social movements in planning, execution, and evaluation. At the same time, consulting movements and service expertise. So we have public consultative boards, we have the centers with years of experience, what they have been doing and how we can learn with them in terms of general planning for public policies. And prioritizing, of course, access of more excluded groups to employment, health, and social care, especially in time of crisis like this. At the same time, we could see that LGBTIQ plus movements and charities, they created their own alternative actions for protecting, promoting health and social care, and promote even creating their own guidelines for health safety in terms of COVID, including Conexão G, but also other groups as ANTRA, national alliances. They created their own reports and guidelines. So we have to read, to hear this experience and empower and expand the state-funded services, which are already an amazing achievement in Brazilian public policies that we should go further. There are some reference, and And also just a final word that reminding about the strike at UIM, and not only UIM, in the higher education organizations in the UK, for 4 reasons: for fight in terms of fair pay, job security, manageable workloads, and equality, which somehow we must say that they are connected with the topic today, because also we see that race, gender, and sexuality, they are part of, they are some of the intersectional reasons for inequities for staff, while we must consider that, for instance, working research, most of the working research is casual work with low payments, which is something that should be addressed, what kind of research we can do in precarious situations. That's what I have to say today. Thank you so much, everyone, for listening.
Thanks, Lauren. Yeah, I often think every time we revisit this data in this study, it's like just reminded that, I guess, just how little there is. And so even within, you know, not the most representative sample, or we could wish for more diverse participants, you know, all day, it's still a contribution, and there's still really interesting things that come up. And I think interesting to see in all 3 talks so far, the way that, you know, people navigate through developing their own strategies in the absence of something else, like an adequate UK health system for particular needs, or in the absence of COVID policies in general, right, or whatever that is. Yeah, and then obviously that plays out at different scales, including at a kind of grassroots level, which is a bit different to what we've been talking about so far. And Maria will tell us a bit more about in Brazil. So next up, thank you.
Thank you, Billy. Hello, Jack. Hello, Luan. Thank you, everyone who is watching. I apologize beforehand because I was planning to prepare something better for today, but some things happened the past few days, and I'm almost not sleeping, but I could prepare fast PowerPoint just to bring some information, some general information of the situations, specifically in the favelas in Brazil. So today I'm not speaking as a researcher, I'm not speaking as a professor, I'm speaking as a trans activist who works in favela and who was born in the favela, and who wants to share with you the view of the favela through the work we have been doing there by Grupo Conexão G. And I think it's, of course, important for all of us to think strategies of resistance, and most of all, to think strategies of ethics and life, to deal with the virus or a pandemic that is not only coronavirus, but the government itself, and also the what I call cisgender fundamentalism, which I mean, and I understand is one of the main causes of the situation that we have in Brazil, and of course that produces this paradox. When in one hand we have rights, and we can access in certain terms these rights, such as names, surgeries, free surgery, SRS surgeries, access medicines. On the other hand, it is one of the most dangerous countries for an LGBTI person, especially for a Black trans person. So these contradictions tells a lot of what I want to express in terms of these terms, these analytical terms, cisgender fundamentalism. Anyway, let me share my PowerPoint. Yeah, I hope you can see this. It's, as I said, it's something really simple. I did last night. I am in Turkey right now. I couldn't get back to Brazil, so I decided to keep my trip as planned before. My name is Maria, and you can meet me or find me through my email, which is there. And I want to talk, starting my presentation, giving an overview of what's going on in terms of the impacts of the pandemics in the favela. As you all might know, we have lots of issues in terms of water services, sanitation, topography and habitability, superpopulations of these spaces, communications, health service, and public security, and of course, it's militarized. Oh my God. Militarized urbanism, that rationality that is very much particular in Brazil and that impacts favela in a very specific way, especially during the pandemic. Well, when the COVID has arrived in Brazil, the first case, it was in the beginning of March 2020, authorities started saying that it was important to wash hands and to keep social distancing. But what they did not talk and what they did not inform us was that in those places, and believe me, those places are a lot in Brazil, especially in Rio de Janeiro, the water service is a big problem, such as sanitation. So clean water and sanitation are two main issues that you have to deal in order to keep our health, in order to prevent and prevail COVID-19. But it was not possible in the favela, of course. We have this structural issue, and NOSI actually was made to address the problem. But what I want to bring to this discussion, which I think is more interesting in terms of how we can understand the favela and the diversity in favela, is specifically the topography, the aspects of topography in the favelas. Favelas are not the same. Slums are not the same, they are different. And they are different not only because in terms of territory they are, but in terms of topography they have, in terms of the housing system they have, in terms of services they have. So when I bring topography and habitability, I'm talking about a complex system that creates a second city inside a city, and it is not only enough to say in terms of periphery, because it's inside the city itself, and sometimes in the core, in the heart of the city itself, such as Maré, such as Morro do Turano, where I was born, or for example, Providência, which is a very central favela, and favelas in the south area, the richest area of Rio de Janeiro, for example. What happens in those places is they have very particular types of housing, small alleys to go through where people transit there, and also houses in terms of material, and space, of course, and services. So it was, in my opinion, one of the biggest problems, because if a favela is in a hill, what's called morro, the services tend to be worse than in a flat favela, as for example, Maré. And we can notice that, for example, in terms of presence of organizations, social organizations. Maré, for example, where I work, has many organizations. And if you look, for example, to Vila Cruzeiro, another favela close to it, linked to Complexo do Alemão, one of the biggest and most violent favelas in Brazil, it has less services and less human rights service, less organizations. And having less organization, it means that the support and the strategies to combat COVID was weaker, or was, in general terms, less efficient than it was in Maré itself. Another example I can bring, and that makes difference there, in terms of housing, habitability, topography, was the vaccination process as well. Flat favelas tend to have more health services than the favelas in hills, and it brings more complexities. I'm not saying that the flat favelas had the ideal services. I am saying that these places has particularities that we have to observe in terms of how can we define favelas in terms of services, and of course, the impacts of the COVID, of the pandemic itself. Another thing that I think is important to talk to you today, just to give an overview of what I'm talking about, especially in terms of favelas and these discrepancies of services, was of course the public security and the idea of security back in Brazil. And because it is we have our past rooted in slavery, in authoritarianism, in dictatorship, it somehow produced resonances in our times, especially in those places. And we've seen during the pandemic an upsurge, an increasing of police violence in territories of favela. And that was a lot. We have an increase of 56% during the pandemic in the favelas. It means that we were fighting not only against the virus itself, the biological pathogen, but another type of pathogen, another type of virus, the violence and the rationality of militarized urbanism. So it was a big issue because it represents cuts of services like electricity, like access to water when we have it, access to education, it destroys communication. So it was also part of our problem during the fight against the virus, and it is still. Just to give, let me just put this here. The impacts on specific groups now, I've got this from USP. It's not mine, but it gives us some important data in terms of how COVID has impacted specific groups, especially Black women, migrant, poorest workers, and LGBTI persons. And I'll focus on Black women and LGBTI persons. So a chance of a Black woman to die or to be infected with COVID-19 was 100%, 111% higher than a white man, for example. So I'm not sure if you can see the ponteiro do mouse. I forgot how to say in English. The point of the where I'm pointing, whatever. But here we have the groups in terms of occupation or sector in the first column. In the second column, we have the occupation itself. And the third column, we have Black men, then white women, and then Black women. So here, the first one is security, then health, then those are general professions, and then the professions itself, the occupation itself. So the workers in security, when they were, because it's majority a male activity, the chance of a Black man to die with COVID-19 was 34%. But what I want to show you specifically is in the down at this graphic, where we can find down domestic services. And we're gonna see that Black women which are the majority of the persons in doing this type of activities, has 111%, or almost 112% chance more to die with COVID than any other group of persons. So what I can discuss here is, where are trans women? Where are LGBTI persons? We don't have official information, at least not as far as I know, of Black or LGBTI women, trans women, the impacts on these specific groups. What we have are general information, such as the violence due to the social isolation and so on. So we decided in Conexão G to offer and to try to offer support during the COVID-19 pandemic to the groups. And what I found out was that we didn't have many. I'm sorry, someone in Brazil is calling, and I'm just getting nervous. My heart starts beating anyway. So we had this issue that we had like a basic basket to serve food, and in Conexão G, the group, the organization inside the Favela Maré, but we didn't have. We had a few amount of these things, and we have to decide where we should deliver, to whom should receive those food and masks and so on. And what we found out that it was that we needed to understand the vulnerability of the vulnerables, from the vulnerables, and how to prioritize then the vulnerable from the vulnerable. And it was quite a big challenging, because we didn't know, and we didn't have the instruments to measure that vulnerability. And it was not enough, for example, to create a form to try to understand that, because we have, at least in terms of LGBTI people living in favela, a huge group that cannot read or cannot or do not have cell phone or computer. So we couldn't just simply send them links to fill in the forms. We had to reach them somehow. So it was the first difficulty we found. And the second, of course, was the police incursions, the police activities during the pandemic. It was a lot. And I remember that at least in 3 times when I was there, particularly in different favelas, not only in Maré, we couldn't work. We went there to deliver food, but we couldn't get in the favela because there were so many shootings. So we couldn't feed people. We couldn't give them materials to protect against the virus itself. But in general, the LGBTI situation in Brazil is really complicated. I think Luan has shown an important and relevant overview. But also, I think it is important to talk about what I call transgendered racism, which makes, and we found out that during this process that trans persons, specifically Black trans people, are the most vulnerable among that. And we did not say that. We found out that as a result of this small research process in 5 favelas of Rio: Complexo da Maré, Jardim Palmares, Cidade de Deus, Vila Cruzeiro, and Rocinha. Those are the 5 favelas where we had to work. And during applicating by calling and requesting the presence of people to understand the situation, the economical situation, the housing situation, the health situation, the alimentation situation. We found out that Black women, Black trans women were the most vulnerable, and they are also the most who are killed in Brazil. This graphic is by ANTRA, National Association for Travestis and Transsexuals in Brazil. And it was showing it already to us in 2020, when 82% of the persons murdered in Brazil were Black. Also, most of these persons worked in prostitution. It was, and it is actually, the main activity of a trans person in Brazil. Most of them are Black and live in peripheries. So it was a big challenge, because when the social isolation came, trans people couldn't keep working, couldn't keep doing their activities or work activity. So they had to expose themselves to the virus because they kept in the street, but there were no clients. And again, most of them, 58% of them, sex workers. So these are, the graphic is reproduced, just a small part of it. With we have so much more information I can share later with you. But basically, I want to focus 3 aspects. I think it's important for us to understand what happened with these people during the pandemic. The first aspect is in terms of income, of salaries itself. Almost 40% of them has lived with something like 17 US dollars per month, around 10 reais. 1,000, sorry, I'm speaking English, so I'm speaking Portuguese. 1,000 reais, something like $17 a month. And most of them, again, Black and sex workers. Again, most identify themselves as trans women. And an important thing, we also addressed service to Black cisgender women. That's why I was talking about Black people, because most of them, or a big part of them, are single mothers. They have kids and they don't have a husband, whatever, or lives alone with the kids. So we understood it was important to offer support for those women as well. Travesti is a social identity in Brazil, very Latin America. It's a transgender person, but in terms of a Brazilian, very complex identity. I can't explain in few words now, but we can translate it generally as transgender persons, trans men, and non-binary people. And again, when we compare these data, what we found out is that Black travestis and trans women are in the situation of more vulnerability, of the most vulnerable among the other groups. And again, they are those who are receiving 17 US dollars monthly when they have it. Sometimes it's way less. We found cases where the girl, or a Black girl called Sarah, she had to leave the past month, when the first month when we started doing that, it was in April 2020. She had only the amount of $10 to leave the month, to eat, to pay for a sleeping area in the street. We have these services and so on. And in terms of education as well, we have a large group of uneducated ones. So it also bring complexities for these causes, and of course impacts on the strategies to combat and to prevail COVID-19, because it's not only about offering vaccines or masks or water. It's beyond that. It's about citizenship. It's about fundamental human rights. It's about the right to have your name respected when you search for health services. It's about to have where to stay, because many of them do not have houses. Many of them even live in favela, sleeps on the street. So there are so many complexities. And again, most of them are trans women, Black trans women. So I want to focus on that because I call this transgendered racism. And one of the causes, in my opinion, is this cisgender fundamentalism that we have to deal every day in our life. It's not only about transphobia, it's not only about LGBTI phobia, but it's about something that's rooted in these phobias we have to deal. And it is caused as well because we have this cis-heteropatriarchy and this cisgender fundamentalism. And of course, the representation, the archetype of this mass, sorry for the word, is Bolsonaro, Jair Messias Bolsonaro, the president of Brazil. And he has said a lot of things. He's a genocide, he is a sociopath, he is everything worse, and nobody deserves this man. And I'm sorry, guys, I hate this man. And he said a lot of horrible things. I think Billy and Luan has spoken about this, so I'm not going to extend. But what to do? That was our questions, our concerns when we were doing this service. What to do? Is enough to give food? Is enough to deliver masks? Is enough to make a list of the names and send to local healthcare system? Is it enough? What to do? What can we do to prevail COVID, to prevail this double pandemic, the violence and the virus itself? First of all, I believe that we have to work in coalition. I think the best strategy for now, at least in South America, I think the reality in UK is a little bit different, but working in coalition can give us not only the strength, but the tools to reach where we want to reach. For example, to reach a table at the UN or to reach the International Human Rights Courts, especially when we work in organizations so small as Conexão G. So working coalition is one of the strategies we should try to point out. The other is to reinforce the importance that education is the main key to escape that system itself, and to reclaim and to call for our rights. But this is not only. We have to work with politicians, we have to create public policies, we have to work in terms of changing the law. I'm at this moment in Turkey, and I've known some activists here, and they could make a list of the issues they have. I've been in Mexico, I've been in Thailand, I've been talking to activists back in Iran, I've been talking to activists in Ethiopia, in Ghana, and all of them could list things that we should do, but all of them will say that we have to change law, and to change and make law more diverse. And to change law, somehow we have to change this cisgender fundamentalism. I think it's very important. And to change this cisgender fundamentalism, we have to occupy the spaces. As Black trans persons, we have to be inside the main universities. We have to be inside the main hospitals. As workers, we have to be in the main industries across the world. We have to sit equally at the table at the UN and say equally, we exist and we have to change, and this change must come now. We can't wait 1 year, 2, 3. This now, because we are dying. And the ones who are most dying, or dying first, sorry, the ones who are dying first are the Black ones. Black women, Black trans women, cisgender women and transgender women, Black men, migrants, Black migrants. And we have this issue. We can't think in terms of prosperity and a future or tomorrow, whatever the word it is, if we do not face the problem of LGBTI phobia with the problem of racism. Both problems works together and bring difficulties to our life, bring death, bring the lack of breath. So these are main issues, in my opinion. So I'd like to finish my presentation. I'm sorry if I pass the time, but I have a short video of some of our actions in the favelas. These are the group I have the privilege to work with, Jomara, and the others, Larissa, Chris, and me, of course. And this is our space, a very small space we have in Favela da Maré. And I'd like to reproduce what Ventura Profana says. The elderly will have dreams, the young will have visions. I have this video, I think it, yes. Hope you can listen.
Assim, quem tem fome tem pressa, né? Nossa, mano, eu tô aqui, eu falei pra minha mãe, né, mas eu tô emocionado. Como é, assim, o prazeroso entrar assim, na linha de frente, cara. Botar a cara assim, distribuição das suas coisas, gente, mas tem que ter um psicológico babado. Tu viu a menina emocionada falando que o casal se emocionou recebendo uma cesta.
Ora, pois, quando fomos amarradas e lançadas na fornalha, em sua mais alta temperatura, tornamos dobrados diante do trono de Deus.
Sorry.
Formamos branco em festa, nossos luz em catedrais. Conhecemos os mistérios com eles andar, não mais calvar. Arrebatamos das mãos do Senhor as chaves de nossas cadeias. Dançamos em a a Sara Case, uma moradora de rua, me dá até vontade de chorar porque ganhava essa cesta aqui, que agora eu fico um bom tempo sem passar fome, graças a Deus, graças a essa instituição aqui que eu estou fazendo curso, que está me ajudando muito. Onde? Conhece nesse dia, correge na fonte sobre os gêmeos. Para
Não ia te falar, não. Mas eu chorei contando pra minha mãe. Sabia? E isso vai ficar na minha memória. É emocionante.
This is it. Thank you so much. And I'm sorry, I wanted to present the full results of the research itself, but things changed and I just could present a part of it. But I hope we have the chance to talk and to discuss some more about this. Thank you.
Thank you, Maria. Yeah, just really fascinating and I guess sobering to see the kind of lived experience, different context to what, me and probably many others here on the call see each day. Lived experience of, some of those bigger structural issues that and processes that we've been talking about and that you highlighted there, racism and, privileging of certain people over others and what that actually looks like in day-to-day life. I think was really profound there, and I think connects with all of the talks today actually. So thank you very much for sharing with us. To the participants we have left and the panelists, we're over time. So I will hang around if there are questions. If anyone has to go, panelists included, that's completely understandable. And okay, otherwise, of course, you can send any questions to us via email. But for now, if there are any questions, we can stay around for a little bit longer and have a bit of a chat if you wish. So yeah, you can use the chat or you can use the Q&A, it doesn't matter. There's, we can see them both. Thanks, Jack.
I think one of it's really interesting trying to think, and kind of split my head in between a Brazilian context and a UK context. And I think, we've ended up coming to this research with these two focus out of practicality more than anything, because of who our networks are and who we are. But I'm interested to think how the rest of the panelists think as well about how we are able to draw comparisons and ideas from social situations that are seemingly very much on the surface so different and so distinct, but really what can we learn by having these kind of case studies that are seemingly so different, yet there are things that connect us in terms of the different ways within which we're discriminated against. Very much when Luan was talking and Maria was talking about the levels to which already existing racism within the Brazilian context was even further shown and revealed through COVID as to who is most likely to get COVID, who is most likely to die, are also the groups who are already most likely to die of other things in that country as well. And the one thing that we have in a UK context, and particularly within our research, is an invisibility of not even knowing about the situations really of Black trans people and trans people of colour. That it makes it even more difficult to approach the questions of racism, I think, in the UK context, because we can't even get to the communities that we need to get that information. So I think listening to the Brazilian stuff makes me think about what's missing from the UK, and I'm not sure how we go back. It's really difficult to access those communities in a pandemic when we've only got online. But what do you think about the usefulness of being able to try and have this comparison between what's going on in the UK and what happens in Brazil?
Really? Do you want to go, or can I?
Yeah, you can.
No, I think it's a good question, Jack, and it's really good to hear all those different perspectives. Well, I'm especially interested in public services and public social care. So it's a research interest for me, and as a practitioner in Brazil when I was there. So one thing to learn, I think, and you show that when you're showing the process for healthcare, is that we must improve and strengthen our public services when things are doing better. So instead of, because it's a very common political discourse that we will do that, and Maria stressed that we'll do that later, or with time, or slowly. So, and then we have crises, and they will get worse and worse, those crises and interruptions, which are the worst. Right now is well, during the lockdown, it was almost impossible to improve the service because they were closed. So we have to push as much as we can in the moments of at least some kind of calm or lobbying or possible access for that. And we can't wait, because each time that we say something can be wait, or a group could wait, a group, so we could postpone for a group, we are risking that this will be a very long time. And especially, I'm interested as a psychologist, we are saying that those people can wait, even if they won't survive, many of them. Because we're talking about people who may not survive for this time waiting. So I think we have to push for both, and in both cases, and I think in Brazil that happened in terms of healthcare, social care, even we have lots of problems, is very, very restricted, but we still have some services that were achieved through strong movement during more center-left-wing governments, or even center-right local governments sometimes, but that we had enough space to push. And now it's really hard to come back. We are going slower in terms of improving, but it's really hard now to close services, for instance. Close definitely, even they suspend, but it's really hard to close because we have the service, the history, etc. This is one thing. Another thing, especially think about Black trans people, for instance, and its invisibility, trans people of color, trans immigrants, etc. We have something very particular in Brazil. We have some Black trans researchers, lecturers, and professors. Maria is one of them, but we have some professors in full-time permanent position who are Black trans, Black travesty scholars. So they're producing knowledge from the core, exactly inside of the monster. I think that's also helpful in terms of it's not producing about someone else. We have some, in general, practitioners, lawyers, psychologists, medical doctors who are in services producing or creating their own, even, and it's interesting about the healthcare system in Brazil, that you can create some degree of gender healthcare service locally. Even if you can offer surgery, you can, at least the municipality can offer many times hormone therapy. So you can at least start, even if the queuing for surgery will be really long, sometimes you can have access, not so long time to get access for hormones, at least in local authority level. In some specific cities and towns is not general, but that's possible. So, and sometimes it's because the practitioners are working for that and they create the service, etc., in working with social movements. So I would say those things that when Maria says that we must see, and people must see equally on the board as professionals, as researchers producing this action.
Okay, thanks. Because they've been waiting so patiently, I'm going to move to the question, the Q&A, and someone else, say something through text. So from Jazz, for you, Jack, the positive impacts of isolation on transgender people. Do you think there has been a rise in people either coming out as trans or questioning the gender identity over the pandemic? And if so, will this have a knock-on impact on access to healthcare?
Yeah, to answer that briefly, yes and yes. It's really difficult to get clear information about referrals because they just this is why social media analysis is really, really important, actually, because to be able to see where people are communicating about where they're getting where they're going to for referrals from this, you can see that there's potentially a rise. So there is potentially a rise in adults, and this is from, this is the joy of qualitative research. This comes from people self-reporting because the information's not there in the healthcare system. There is a running theme of people who have taken this opportunity to actually, anybody that's involved in trans healthcare anywhere in the world will know that you become an expert admin person and healthcare provider yourself because of the life admin that is involved in tracking down how to access healthcare itself. And that takes time. It takes a lot of time. And it's been the pandemic that has given people the time actually to find out even how to go and do it. So yeah, I said at the very beginning of my paper that when we look at the scary numbers of years now involved in wait lists and how long it's got, that is a combination of an already broken system that got paused for over 12 months, but it's also because there are more people being referred. And I think the other thing that increases the pressure on the UK system, which just needs to be dismantled and built from scratch, because we're at that point where it's just so broken, is that people forget, and I often forget, and it's only when I talk to the parents of trans children, that the pressures in our system aren't just from adults asking to be referred, and it's not just from new adults asking to be referred, but there are over 2,000 children waiting to be seen and growing up. And they too will feed into the adult system the minute they hit 16 or 17. So, we can't forget about the children who are becoming increasingly aware, and the parents who are becoming increasingly aware of listening to children who are questioning their identity and seeking support also adds to that pressure as well. We've seriously hit breaking point, and the frustration is there's no response to it whatsoever. You'll often hear the Conservative government, whoever's the health secretary at that time, will talk about how we're implementing pilot schemes to make things better. That was a long time ago. The 4 pilot schemes that are operating now were launched, the ideas around that were launched in 2018, and they're not new services. They're picking up some of the slack from 4 major cities in the UK, and that's it. So yeah, there's big implications, but very similar to what I was saying about the transmasculine surgery and the problems around the NHS contract there were covered up by COVID. Actually, COVID will be used as an excuse as to why GIC services are so much under pressure, and COVID is not the reason. If a good place to go to look at writings on that is Transsexual UK's website. They've written some really interesting reports and blog posts on how we're not to become accustomed to hearing that COVID is the reason for all these problems, because the problems were there in the first place.
Okay, thank you. Maybe I'll just have one quick question, and if there's no more that come up, then we can end it there. But for Maria, I was curious, in the work that you're doing in the favelas, I guess I'm, in a broad sense, sort of like, who is involved in that? And what I'm really trying to get at is, within the kind of broader LGBTI community, who do you find is sort of the most visible or active kind of advocates for Black trans women in favelas? As in, are the more privileged people within the LGBTI community supporting, or is it, you know, the most disadvantaged fighting for themselves? So I kind of want to say, I guess, but I don't really want to, but, you know, do you see cis white gay men supporting your project, you know, as well as the people most affected in trans people of color?
Billy, thank you. I believe that in general, the LGBTI community has been guided, I would put in those terms, by white cisgender men. It is not a big deal, I think, when you consider the diversity inside the LGBTI community. If you try to harmonize the experience of LGBTI persons as I don't know, put they under the umbrella of the gay cisgender white men, we have a big deal. We have a big problem. And to be honest, this is an issue in Brazil because most of the LGBTI actions are focused on white men and white gay men or middle class cisgender men, I believe, because they are in the universities, they are the politicians, most of them, they are the professors, they are the businessmen, they are spreading the pink money all across Brazil. And meanwhile, some groups are being forgotten, is that correct? But I think also we have to bring to the table terms as territoriality, migration, pregnancy, sexual reproduction for trans men. It's a big issue, for example, for trans men in Brazil right now. We have a very good, let me correct. We have inefficient services in terms of public service, health service. However, it is still focused on a cisgender perspective, which says that, for example, only a woman can get pregnant. And it's a problem because trans men are changing, are rectifying their civil identities in Brazil, and they get pregnant. Even in relationship with travestis or trans women, they are getting pregnant, and I know a lot of them. And they go to treatment to have the babies, whatever, and they go to hospital. And what they find when they get there, I'm sorry, sir, we cannot offer you the service because it says that only women can have this type of services. So you have this. It's in terms of reproduction, and in terms of territoriality, we do not bring to table terms of as favela, as indigenous LGBTI people. We don't bring terms of migrant LGBTI people in Brazil. There are a lot of Venezuelans at this moment in Brazil. We don't bring the table the topic specific of racism in the LGBTI community. So I think in general, the problem is not the white cisgender men, but the white cisgender rationality. And again, cisgender fundamentalism. I think that's the big issue. If you want to discuss diversity in terms of favela, in terms of people of color, in terms of indigenous people, traditional people, we have to fight against cisgender fundamentalism. I think that's the big problem. So yes, we have allies, we have men allies. I believe you are an ally. Luan is one of the most important ones. We have amazing people fighting together. The question is, is it enough when we are surrounded by rationalities and the construction of law based on a white and class and a cisgender perspective? So we have to change the rationality itself. It takes time, and I believe it is possible.
Yeah, thank you. Yeah, I get, and what you say is just along the lines that I was thinking in asking the question, I guess, and just that, you know, while our systems are still built from particular norms and perspectives, then everything within it follows those, even if you know, give some rights and things along the way. And those norms privilege people even within our marginalized communities. Right? It reminds me a bit of different, but that concept in Australia where I'm from, and marriage equality was passed in 2017, and it felt like that was the end of all LGBTQIA issues, so that they're done now. And it's like that. It's like nothing, you know. That's the start of, you know, so many things. But yeah. Anyway, thank you. Did you want to say something, Jack?
Yeah, I just think that's exactly why when I talk about our public gender healthcare system being so broken, is, you know, that's precisely the problem with that as well, is the whole British approach to trans healthcare is cisgender. It's based on somebody wanting to become cisgender. You know, it's based on this idea that somebody walks through the door and says, I was born in the wrong body, I want to become a woman, or I want to become a man, and they'll go, right, we can help you, you know, we can help you assimilate to become a cis person, and then you don't exist anymore. And then, you know, it's almost like it's a health system based on eradication of trans people, because it just wants to turn them into unrecognizable cis people, you know. And I think that's it's a kind of a global vision on yeah. I always come back to the point that everything just needs to be completely dismantled instead of trying to fix broken things. And yeah, just turn the tables around and ask the people affected by the services how their services should be run.
Yeah, I agree. Okay, so I'm going to wrap it up now. Thanks for those who stuck around. Thanks to the panelists for your energy and your time and your insights, and for, you know, allowing me to drag you over time. I think it's worse for me though. It's 2:30 in the morning, so yeah. And I'm the one who got us off to a slow start. So anyway, it's my fault and my consequence. Anyway, thank you very much. And if anyone wants to continue discussions, you can email us. Otherwise, yeah, thanks again for your time, and enjoy the rest of your day.
Thanks. It's lovely to meet you all.